Recorded.
Welcome and thank you for joining us today for the meeting of the New York City Health and Hospitals Finance Committee. Today's meeting is officially called to order. I'd like to propose a motion to adopt the minutes of the Finance Committee meeting held on July 11th, 2022. Do I have a second?
Second.
All those in favor, please say aye.
Aye.
Any opposed? Any abstentions? The motion is then adopted. I think we have one action item this month to consider for medical respite operations and services. And Matt or Leora, please read the resolution into the record and take us through the presentation.
Here to present the following for your consideration: the authorizing New York City Health and Hospitals Corporation, the system, to sign 3-year agreements with each of Institute for Community Living, Inc., ICL, and Communilife, Inc., Communilife for the provision by ICL of 26 respite beds and by Communilife of 25 such beds, with the system holding 2 one-year options to renew both contracts for an amount for the 2 contracts together not to exceed $17,960,500 over the potential 5-year term.
Thank you. Please go ahead with the presentation.
Absolutely. Good afternoon. I'm just going to give just a quick background on our housing initiatives at New York City Health and Hospitals, of which respite is part of that. The H&H provides health care to nearly 50,000 patients who are experiencing homelessness and 22,000 who are also clients of DHS. Respite is one of our strategies to provide transitional and permanent housing for our patients. The other strategies are using our land, working with other agencies, and in some cases funding social services in permanent housing. To date, 450 patients have been permanently housed, and over 800 people have benefited from interim housing at medical respite. We'll take a minute now and go into more details on medical respite and these contracts. Marjorie?
Good afternoon, everyone. My name is Marjorie Montplaisir Ellis, and I'm delighted to be here with you to present medical respite because we are extremely proud of our work. We have been the model for medical respite and the problem that we sought to solve were that patients who experience homelessness often stay at health and hospitals longer than they need to because they need ongoing care after they leave the hospital, but they're not able to receive at shelter. So for people who need wound care or physical therapy and other services, they're not able to be discharged from health and hospitals, and they end up staying there longer than they need to. The model as it exists today includes case managers and others at the medical respite sites to be able to help people with their housing case management, as well as to be able to have the medical care that they need that is put in place by the discharge planners. So people who are experiencing homelessness, who are inpatient at H&H, when they leave, the discharge planner will put in place for them services like wound care and physical therapy, and they can go to these 2 community-based organizations in order to receive that care. The goal of medical respite is to be able to stabilize individuals, improve their health, provide the social services that they need, also help them to be able to get supportive housing and to reduce the cost that people, that H&H incurs when people stay in the hospital longer than they need to. So our current contracts are with 2 providers, the Institute for Community Living. Sorry, next slide, please. Our current contracts are with 2 providers, Institute for Community Living and Communilife. The medical respite program was started at H&H in 2019 by various departments at the central office. So under DRISRIP, One City Health had a contract, Population Health had a contract, Post-Acute Care had a contract, and our team, the Housing for Health team, has consolidated all of the contracts, and we are now managing the work with the 2 providers. We began that work in 2020, and currently in summer of 2021, we signed a best interest extension for the 51 beds. 26 of those beds are in Upper Manhattan with the Institute for Community Living. The other 25 are with Communilife. New York City Health and Hospitals has the largest respite program in New York City. There are other private hospitals who contract with these CBOs for medical respite beds, but there are none that surpass the 51 beds that we have been contracting with these two providers for the past couple of years. Next slide, please. We are extremely proud of the work that we've done with these community-based organizations in terms of being able to actually have awesome outcomes for the individuals who go to respite. So we know that we've had more than 1,600 referrals from our facilities, so there is a need. There are many people who experience homelessness who are inpatient units at H&H. The majority of our referrals come from Bellevue, Kings County, Jacobi, Harlem Hospital, and Lincoln Hospitals. The average length of stay at respite is 45 days. We've served 815 patients to date. And of the people who've been discharged, so the 769 people who've been discharged from respite, 35% of them have gone on to stable housing, either through supportive housing, where the respite providers have done the work to get their applications completed and do the process with them, or through the intensive housing case management, they do the work to get people back with their families. They also do referrals for assisted living facilities as well as nursing homes, depending on what the need is for the individuals who are currently at respite. On the next slide, please, you'll see the finance cost savings analysis. Currently, the cost of beds per day at respite is $150. That represents a savings for H&H. We know that direct variable supply and labor costs for caring for the same patients in the hospital are approximately 5 times the cost of people going to respite. We also know that this investment in medical respite directly avoided an estimated $17 million in hospital operating costs. We know, too, that helping people to transition to respite frees up inpatient beds, and so we can estimate that that opens up access for 950 new patients, translating to an estimated net revenue of up to $16 million. On the next slide, you will see the RFP criteria that we put in place when we released this RFP in the spring. We were looking for providers who had at least 3 years of experience in being able to provide this type of care. Since these are community-based organizations, they are not, it's not applicable about the MWE requirement because they are CBOs. The workforce diversity data is included as part of this presentation in the appendix, so you can take a look at their workforce diversity data as well. And then you'll see the criteria and the representatives of the evaluation committee. The next slide lays out the procurement process. The RFP was released in April. Our pre-proposal conference had 12 potential vendors. Many of those vendors are individuals who were just really, really curious about medical respite because it is a fairly new initiative and they wanted to learn more about the work that we've been doing. Also, because real estate is extremely expensive in New York City, we only received 2 proposals because it is extremely hard for a new CBO in this space to be able to acquire the real estate, learn how to do and provide these services. So the 2 proposals we received were from the 2 current providers of respite today. In June was the evaluation committee. Final budget proposals happened in July, and the scoring happened in August, with both of the providers scoring well, and both of the providers are those that we want to consider, that we are coming to you today in order to supply them with these contracts. And the last and final slide is about the contract terms. We will sign contracts with the 2 vendors, Communilife and Institute for Community Living, for a total of 51 beds in Upper Manhattan. It will be for 3 years with 2 one-year options to renew. We will operate 25 beds at Communilife, 26 beds at ICL. In this iteration of the contract, this is the first time where we are putting in place more clinical services. So this contract will include a registered nurse on site 2 or 3 days per week. We have also been doing all of the beautiful compliance work of being able to allow our CBOs some limited access to be able to see Epic and see the medical records of the individuals who actually come to them on site. And we have also been working with Express Care so that we can have the people who go to respite also be able to take advantage of having Express Care or telehealth for some of their needed services. Thank you so much for your time. The last few slides are the appendix with the workforce diversity as well as the performance evaluation for the two providers.
A quick moment to praise the team for a second. I was lucky enough to be the CEO of One City Health at the end of DISRIP. Marjorie was on the team, and this is really an example of Health and Hospitals investing its own funds as a continuation of the prior Medicaid waiver. And we've kept this going for several years. We have the largest respite program that we're aware of in the city, and so just the level of commitment from our system to keep those programs going that many other systems and things ceased when the waiver ended, I think is just a great testament to this team and to our system's commitment to these patients. But apologies.
Sorry, Barbara. Feniowski, then Barbara.
Barbara can go, and then I
Oh,
go.
okay, sorry.
I just wanted to piggyback on the last comment that Dr. Rosa Gil has been phenomenal for decades doing this work, and I'm glad that she has continued so we could jump on with her, because I know that she would have loved this to have occurred many years ago. She was one of our HAC presidents at one point in time. So I think this is a very good collaboration, and it means a lot, and I hope others will learn from our experiences.
Thank you, Barbara. Feniowski?
Thank you. I have two questions. Could you, this funding, I think, first of all, really great work, and definitely the impact is well articulated here in terms of both the patient's care, but also the ability for the hospitals to be able to give care to other patients. But the funding that is allocated to this, is that something that the whatever insurance mechanism we use to cover the expenses of these patients will cover these housing costs, or these are all from our operating budget to finance that? We don't have any way to recover those costs.
At this point, it is all our operating budget. There is we believe, a meaningful offset, as we pointed out, in just the inpatient revenue and the savings at the facility level. There is also, we believe, a meaningful contribution to the risk surplus we generate through our value-based contracts when these patients are in those contracts. We are hopeful that there will be some state reimbursement through Medicaid coming for respite services. There has been policy changes to allow that, but the final regulations are not out. When they do come out, that may be an opportunity for these CBOs to offset some of the costs that they are billing us for, or may open up the potential for even more expansion if we know we have that kind of steady, very dependable, trackable revenue source. But as of right now, we fund this out of operating revenues or margins for the rest of the system, and view that the offsets in other parts of the budget.
But in theory, if these patients were to stay in the hospital, there will be revenues coming. Again, I'm not advocating for that. I'm just trying to understand the logic here.
Well, at a certain point, right? Most of the reimbursement on the inpatient side is kind of episodic and episode-based. So if these individuals are staying in the hospital 3 months, 4 months, 5 months, the revenue doesn't continue to increase apace with the cost of them being there.
I think it's so important. It's with the pace of the cost.
Absolutely.
So thank you again. That's for the other comment that I wanted in terms of presentation. We have been trying to be more consistent on our presentation of both the MWB and the demographics. And I did notice that in this presentation, it was put in an appendix, which is good. but I will request that is part of the main presentation as you present the data and ensure that it's part, at least when we go to the board. That will be my recommendation in order to be consistent with all the things that we are doing.
Okay, thank you. Sally?
Yeah, so it costs us $17 million and we save either 16 or $17 million. Is that right? Looking at that right?
I think the request to contract, it's a 3-year contract plus a 2-year extension. So the resolution under consideration is that combined amount. And the analysis that finance has been very gracious with their time to help us was a 1-year examination. So,
Okay, so I should divide up our total contract amount.
right, so the
Yeah.
annual is less, Sally. So on an annual basis, it's like,
2 and change.
$2 or $3 million.
the 3 million to 3.5 million in change. So, and the analysis on savings and revenue is also, but just based on 1 year. It's not for the 815 people.
We want to continue to track the results. The analysis is sensitive to things like the expected length of stay for the individuals
Right.
and the ability to backfill with additional new patients, and those things have fluctuated pretty significantly over the last couple of years. So I view these financial analyses as illustrative and directionally correct, but we need to continue to build them out and supply you with updates as this proceeds.
Small number of patients, so
It is.
we can really.
I think it's bigger than that. I know personally when our patients came to Woodhall, they came deliberately when they weren't so well to be able to get in the door and then stay for quite some time
Right.
because they were homeless. So there's another hidden cost, if you will, of, and it has two prongs to it. If that person taken a bed, and then those who need that bed badly.
It's interesting, the workforce issues that Dr. Mathone talked about earlier also are intensifying the benefit of this because we can't even really hire more nurses and doctors to take care of people in the hospital. So beyond the financial savings that we think there exists, we're literally having trouble with access. And so if people move out of the hospital to an appropriate level, we gain the ability to hospitalize them, which, we're trying very hard to keep up with the demand for our services. And this is one of the ways that we can help. But it is very discouraging, Sally, as again, to connect it to your discussion, right, that some of the insurers would have to continue to pay for the hospital bed, but are not required to pay for the respite bed.
Yeah.
Because it's not a covered service. But again, because everything is so complicated. For example, if it's Medicare, you're getting a DRG. So you're getting one payment for the whole hospitalization, regardless of how long. That person, you're going to save a lot of money by putting them here. If it's Medicaid and you're getting a non-value based Medicaid, then probably it's not such a great financial deal because Medicaid is paying every day for the day, but they're not going to pay for this. If it's value based, then it's probably okay because they figure in Health First and Metro Plus what our costs are in determining how much money we get at the end of the year. But it gets back to your earlier point that all the actual financials, you can only project using estimates of what you think, the mix will be of patients going into it, and how that space will be used. The good thing is that prospectively, which is what Matt is talking about, you can calculate an actual number. They'll be able to tell you, because for each person who actually moves in, they'll tell you in real time. But again, it's all subject to change, and who you put in, and what it's a little, we've always tried it, as we talked about before, to never consider insurance status as part of, care. On the other hand, arguably, we're caring for them either way, so maybe here it is acceptable to consider, who's paying, because we're gonna care for them either way, right? But it may be more financially advantageous for value-based patients to move, but it's really, the basic framework is all wrong, right? The basic framework should be to take care of people in the right setting, especially if it's less expensive. And we're just living in a system that's so messed up that it's very hard to do what seems like such a straightforward concept, right? We'll take care of everybody in the best setting possible, taking into account the use of the resources. Right? Wouldn't that be? I mean, who could disagree with that?
But I think we are doing that, Mitch, with.
We're trying.
Right.
but
I mean, I think the fact that we are moving the patients over, even if maybe we could get reimbursed if they stayed in the hospital, seems like the right thing to be doing. And from a financial impact, what I see from here is that it depends on each case, whether it's an economic decision that was good or bad, but it certainly freed up beds. We have occupancy rates that are very high in our hospital, and so presumably we're getting other patients in that are now generating revenue. And so I feel like this is an attempt at trying to.
We're trying.
Yeah,
I guess
right.
what I'm saying is
Yes.
the rest of the world is
It's
not trying.
Absolutely,
The
okay.
rest of
That-
the
that's
world,
fair.
and if the rest of the world would try, we would be able to do better too.
Too, right.
Right, because we could create many more such beds.
Right.
Because the demand is there, but
Definitely.
we're limited by the fact that we have to put general funds to
Right.
this, recognizing that even though a large number of these patients are hospitalized, and arguably because the uninsured would still be emergency Medicaid,
Right,
you're always getting some payment when they're in the hospital.
I see.
And so in order to do the right thing, we're paying
Have to come out of pocket.
instead of, the people who are insuring the
Right.
patients. And
It's
that's what's
amazing
wrong.
that we were able to get 1,674 referrals for 50 beds, right? I mean,
The word is out.
Well, another question, I'm sorry, were there other questions?
No, I just have a comment. It's almost like we have our own we have our own redesign team.
Yeah.
And and to not to sound so optimistic, but I wonder how much convincing the modeling that we're doing can convince the rest of the state and
To follow.
to follow. And we have a big enough pool of patients to generate the data. And it might be worth both our time and their time to see the outcome, see this through, at least for another season or two, to see where this goes, to see what we can produce and how much savings it would cost in the end. I mean, we're not talking about gerrymandering care. Because we're not about that. So we are about care first. So if we're not gerrymandering care and just putting a pool of people that we believe we're going to provide sub care to in one place, then we don't have an issue here. We're talking about just what's more practical in terms of the pay per day, and let's figure that out. So I am for supporting this to see if we can make things work and maybe change the country's mind about how we're doing this.
May I just add that a fair amount of marketing is necessary. There are folks who could have gotten more involved, and they are very much stigmatizing the population. And that's a real issue. So I couldn't help but put that out there. And we can do a very good job of marketing the benefits of this.
Thank you. I have one question for you, George. So 35% of patients into housing from respite, which I think is amazing. Like it to be more, but I think that's great. Would we have been able to do that, moving them from the hospital?
It would be too difficult. The lead time to find housing, it just takes too long. The amount of paperwork required to access the housing that these patients would thrive in is quite laborious. And so it's impossible to do it in a month or 2 months if you're in the hospital. You have a little bit more freedom and flexibility. If you're at respite, you're recovering, and then you can start pulling together all the documents. Also, social workers are quite busy and overwhelmed in the inpatient setting, I hear.
Yep.
And so this having this happen off-site is better.
So all these other benefits as well that are
Correct.
not,
Correct.
yeah, not necessarily quantifiable in the same way.
I just have a question about, is there much respite care being funded? I know that, Communal Life in Wheeler happened to have the facilities but they were subsidized to create these respite facilities, right?
I mean, we cover the cost of their, I think if you're asking if Communal Life took the risk in initially
to develop.
finding it.
They did the development work. They created
I think that they accessed a building, without our, we weren't part of that.
No. I didn't say we were, but the ability to increase the number of units is, it's not like we say, well, we got these 2, but they're gonna be 10 more in the pipeline coming down. Or are there, maybe
No,
respite?
the current, right now, these 2 providers are operating 51 beds.
Right.
We opened up the RFP, we were hoping more people would come on, and maybe we can get not an infinitum amount of beds, but maybe we can get another 20 on top of it.
Right.
We didn't have really anyone bite at that apple, so we said, okay, these providers, are exceeding expectations, they're satisfactory performers, their new proposals are deemed reasonable, and so we're continuing, these are new contracts, so, but it's the same provider. But,
I think the pipeline question you're asking
That's
is
the
a very
question. I'm
good
sorry,
one.
I'm not doing
And
a
it's
great job.
we're thinking a lot about it. The state coming out with regulations to potentially pay for this is on one level quite positive. But if the regulations essentially regulate respite like a hospital bed, the economics don't work and the pipeline of building new of these will become, far too difficult. We will, I think, ultimately look at whether we want to build some of our own, we want to repurpose some space to do this, but I think a lot is hanging in the balance of what do the regulations say and how much like a hospital do regulators try to make these respite settings. And there's a trade-off of doing that.
I think, sorry.
I'm sorry.
One quick thing, then my chair is
Well,
going
the
to make me
respite
move on.
is not the last of housing issues for these individuals, obviously. And I think there's a bit of a movement now to try to get people into, public housing and such. More is being done. I don't know what the plans are, but it looks like there's a lot of noise going on that would support people being transitioned into their homes. Once they're stabilized, of course, and they're better and they're managing well, they should be able to get priority for some of the public housing.
Great.
Can I,
Yes.
is there a way
You can.
to signal how much of this is needed within the next 10 years to the public, or within the next
Yeah.
couple of years, not 10 years, but, because I think part of the issue is these organizations they are taking the risk now, right? They are saying, we put a building, this number of rooms or beds are set up for this. And they need to have a sense of like, okay, should I double this, triple it? Because it takes them a few years to basically set it up, so.
I think they're not, in New York City, I would say, no one's building this, right? They're trying to find, they're leveraging, if someone has an underutilized SRO, or they seem to have a relationship with the landlord. In other parts of the country, yes, someone may consider new construction in another building, but ICL and Communal Life or other CBOs would never, I'm being very firm here, I'd be hard pressed to believe they would just build ground up new construction for something unless they had like a long-term contract, to your point. So these contracts are small enough, not small enough, but the term is very finite, that they can develop a master lease or a relationship with an owner of a property that's in compliance and they can deliver. And so
Okay.
they can sever those contracts, we can sever their contracts, these are all, that makes it in some ways less risky because no one's building a new building, no one is relying on us to pay debt service of a new building. It's just existing space that's underutilized.
Great. Thank you. So I'd like to propose a motion to approve the resolution to move to the board.
Second?
All those in favor, say aye.
Right.
All those opposed? Great, the motion is carried. Thank you very much. Great.
Thank you.
Okay. So next on the agenda, John and the team have a very solid report for final fiscal '22 and continued improvements that we're seeing on your efforts here, but clearly we have some headwinds. So why don't you go ahead and
No, thank you. Can you hear me fine? Yeah, so we thought we'd do is just maybe go through our closeout. We finally closed out FY '22, and feel pretty good about that. We'll talk about '23 and then conclude with a report on test and trace. But for '22, we closed the year with $700 million or 28 days cash on hand, which is pretty much where we thought we would land. When you look at the budget, right, we basically broke even. $30 million net positive on the budget, which is fine for us. We spent everything that we received. I think the pretty impressive number is $617 million in higher patient care revenue on a year-to-year basis. That's not against the budget. That's actuals to actuals, and that, in my mind, shows this pretty consistent year over year. This is a sustainable revenue performance, and we saw a bump obviously from the UPL conversion, which generated considerable revenue for us. Volumes have returned to pre-COVID levels. We're 1% ahead of where we were in FY '20. We'll talk a little bit. We have more specifics on those statistics. And then overall, our strategic initiatives in pretty much all the areas either were at budget or beat budget. $614 million has been generated since the base level. So again, all those sectors performing, I think, fairly well. Next slide, please. Can I do this one, Jim?
Sure. Yeah, so just quickly on our cash performance through the first, our cash flow performance in the first quarter of the year. So we dipped a little bit from our year-end of $700 million that John noted, but that was to be expected. Through August, we were at about $600 million, and as we close out September, looking to be at about $550 million, which is a very stable, steady place for us to be. Despite all this, and getting to the next slide on risks, we're continuing to work with the city on our liabilities to them, just to make sure that we maintain that stable position as we get through the rest of the year.
Slide. So we're always, we're watching our risks. And we've taken a couple off the board and added some new ones here. But the wage pressures and related costs, the effects of inflation, obviously impacting the entire economy, maybe more so within the healthcare sector. So we watch that very closely. Temp nursing costs is putting pressure on the budget. We're watching that closely. The number of temps continues to increase, and actually, I think we're enjoying more nurses as we look at the ratios in anticipation of perhaps the next COVID wave, or even the effects of the flu or the need for additional vaccination as we enter into the fall. So we're watching those costs closely. The NISNA committee recommendations could cost us upwards of $10 million, but we thought that's an investment worth making. And I think Natalia and team had a very good experience with NISNA at the table. And then the last one is Medicaid recertification, and we've enjoyed as part of the federal government response to COVID, is they put a freeze in place in terms of people's ability to be enrolled in Medicaid, and we expect when the public health emergency finally is concluded that they'll begin the recertification process. And we've enjoyed obviously a considerable financial benefit through expanded enrollment, and which has helped out our risk pool. So we're keeping a close eye on that. We thought the recert process might start in November, but we think it's going to be delayed once again. But at some point that will happen, and there's a lot that will affect the Medicaid program in general, and certainly us as they begin the recertification. So those are the ones we're watching. Financial performance. I'll turn this over to Salima. Yep.
Hi, Salima Tyler. This is just a little bit of more information regarding that number John quoted earlier about the $29.7 million budgeted variance. It's driven by an overage in the revenue as well as an overage in the expenses. And in the following slide, we'll get into a little bit more detail there. Next slide. So on the revenue side, I'll direct your attention to the little chart at the bottom. These are where the variances are coming from. Again, it's driven by our volume coming back higher than expected in the budget, as well as us performing better on our strategic initiatives. Quickly, if you just look at the increased volume, it's worth 307 million of our variances coming from that. Increased rates, again, due to rev cycle and other initiative improvements. Our risk pool came in a little bit higher, well, a lot higher than budgeted, partially attributed to the fact that we only budget for a 12-month period, and we got risk back for more than 12 months. We got reconciliations from COVID surge, and Metro Plus reinsurance. And then we have other revenue that came in higher, attributable to 340B, DME, which is direct medical education, few grants that came in higher, and appeals and settlements, which we don't budget for. Conversely, on the expense side, we came in 630 million above target in terms of our spend. 291 million of that is coming from COVID, should not be recurring. Agency patient care temp staff coverage is the other big ticket item that's driving our costs up, and that's 243.8 million. In that particular bucket, a lot of it is driven by RN utilization. Some of it is driven by, a lot of it is also driven by the fact that the rates are higher than what we've set in the budget.
So I just wanted to share some of the fiscal year 22 achievements in the area of the revenue cycle. A crowning achievement is that we reduced the primary denial rate by 6 percentage points, which was a huge percentage reduction. It was a lot of work combined with revenue cycle, managed care, the facilities, all working together with the payers to understand and avoid denials coming in. Salima talked about the drivers of this, but the cash posting relative to those pieces that get applied to the patient accounting system was increased by 10% as compared to the prior fiscal year, which was $457 million in incremental floating through the billing system. Allison will talk more about this, she'll expand on this, but we increased the overall financial counseling coverage from 79% to 89%, which generated about $154 million. And just 10 percentage points covering uninsured patients is really a huge increase for a single year, and we were particularly proud of that. I've said this before here, but clinical documentation improvements is a gift that keeps on giving. And combined with secondary review, we built an internal secondary review process, and those combined generated $124 million incremental this year. We're particularly proud of our training program. We call it the Revenue Cycle Institute. We had over 5,000 individuals participating in revenue cycle training in fiscal 22. We're constantly developing new modules, and in fiscal 22, we developed 13 additional instructor-led modules. The No Surprises Act was legislation that was effective in January of 22. There are a lot of requirements. This is a patient protection legislation that helps patients avoid surprise billing. And part of our compliance with that is that we need to provide scheduled patients a good faith estimate in advance of their scheduled appointment, which lets them know of the patient financial liability. We were compliant with the regulation from day one, and in addition, we have automated those good faith estimates just about 100% of the time. So we were able to comply without adding staff, which is somewhat miraculous. And then looking ahead to fiscal 23, our focuses are really moving from, I have used this before, moving from good to great. So moving from the median performance level in terms of our denial rate and moving to the top 25% we benchmark against other Epic customers. We're also looking at components of the patient financial experience, so those interactions with patients around their finances, and looking to improve that more, really leveraging the functionality within Epic to really enhance that experience for our patients. And then I'll say lastly here, these are not the sum total of our initiatives for fiscal '23, but really to improve the timeliness of charge capture. We've focused a lot on improving our charges, and now we're looking at the timing of that to make sure we get those charges in on time. And I'm going to turn it over to Allison Hartman to really dig into those financial counseling rates.
Thanks, Margie. And I think we really just wanted to dig in a little bit here to show our year-over-year performance improvement around a number of our financial assistance KPIs. Margie already touched on this in the highlights, but we've seen a consistent year-over-year increase in the percent of the uninsured patients who are having a financial counseling interaction, along with the percent of those who our financial counselors are interacting with, how many patients are being successfully enrolled in either health insurance coverage or financial assistance. We'll touch on this a little bit more in a moment, but we do track a number of other indicators, including those patients who are screened after being discharged from one of our emergency departments within 72 hours of discharge, as well as our outpatient scheduled population, what proportion are being screened within the 90 days prior to service, and looking at both our current performance and some opportunities here. Just our success around some of these metrics has continued to generate increasing revenues year over year. So what we've shown here is our performance across the last 3 years. We actually exceeded our expectations in FY22. So we continue to reevaluate our FY23 target, as well as dig into the remaining opportunities. So we've highlighted here a number of additional opportunities, things that we are continuing to dig into and to try to drive action around. That includes continuing to look at those opportunities to screen our uninsured patients and successfully convert those screenings into health insurance or financial assistance enrollments. Assisting patients with maintaining continuous coverage by doing proactive outreach to our NYC Care members, as well as our Medicaid recipients, given the expected implementation of recertification requirements, again, after the end of the public health emergency. I touched on this a little bit, but looking at trying to optimize the timing of screenings, including trying to increase the proportion where scheduled patients are having that interaction prior to service, or for patients seen in our emergency departments within 72 hours of discharge, really for a better patient financial experience. We're also looking to pilot a one-stop model for public benefits. We're looking to begin that by trying to assist patients that we're already screening for health insurance or financial assistance, trying to connect them to SNAP benefits if they qualify, as well as some other targeted initiatives with special populations. So just really trying to dig into those remaining opportunities and drive more improvement here.
Can I just add on that? Because there was a nice discussion at the strategic planning, at how to get a little bit higher than the 90%. Allison and her team has done an excellent job. But the 32% there, outpatient screening prior to service, I think we can move that number, right? I think, again, through a little bit better coordination, but when the patient is calling us, reaching out for services and scheduling that visit, that runway between the time they place the call and we schedule the visit to the point in time where they actually come in for the visit, we think is opportune to try to secure either insurance or NYC Care. And I think we can do a little bit better job there. So we'll come back perhaps with some information. We're going to study, why it is and where that's occurring, but there's opportunity there.
Great, thank you. Barbara, you wanted to?
Oh, you just answered my thought.
Okay, great.
I thought there would be an opportunity somewhere along
Yeah. And I would also say, like, the one-stop model, I think, is excellent. It's kind of, our financial counselors are actually kind of interested in this, right? Where we're not only just securing insurance, but we're also trying to help them with other benefits, right? Looking at us as more than just being a hospital, right? We can help them with, other services that they're qualified for, and there's billions of dollars out there of services that people are qualified for that don't get access. So.
Right. That's great. Thank you. Fiscal '23?
Sure, we'll start with going over little sneak peek of how we're doing in terms of revenue, July and August of this year compared to July and August of FY '22. Our inpatient volume is 3.7% higher than FY '22, and it's within 1% of reaching pre-COVID levels. Outpatient non-testing volume is up 2% from the prior year, and we're exceeding pre-COVID levels by 4%. Inpatient and outpatient cash is down 3% compared to prior year, but this is 100% attributable to the Coney Island name change. Their bills were being held, and so that's artificially driving our revenue down temporarily, but without that, our revenue is actually up 20.7 million. Metro Plus and Health First enrollment is up 8% compared to the same period last year, and it's 2% ahead of the budgeted target. So far, so good.
Wonderful.
John Salima went through this a little bit earlier, and then basically in this piece, one of the things that we are keeping an eye on and impacting the first quarter on the expense side of the world is our nursing costs. And really, the focus here is is on our recruitment to make sure that we're able to get our full-time nurses hired against our models for inpatient, outpatient, for inpatient and ED, make sure we're fully staffed there so that we can start to safely bring down the utilization of temps. And also, the good news there is there's a lot of work and almost at its final stage at this point with our OR and behavioral health areas, and part of that is our nurse staffing there and making sure that we also get to the point where we are maximizing the utilization and recruitment of nursing in those areas. So a lot of work to be done there.
I know that Dr. Sunias is not here. I'm a nurse, and nursing have become a revolving door, unfortunately, with the travelers and those who came here for employment, and that's really was their goal. So keeping them is another question. That particular cadre. But we've worked with the universities, the nurses, student nurses are here. We can maybe spice up a little bit the offering. When I was chief nurse, I would make sure they were with me on summertime. For the benefit of that student nurse and my regular nurses, they need to learn to teach to reinforce their clinical skills. So I think there are opportunities, and I know Dr. Sunias has her hands on quite a number of initiatives. So hopefully we can get them to stay with us once they're here for a while.
It's not very difficult. I hope so too.
Very difficult because there are nurses who pulled out their license during this period because it was a big bonus, if you will, financially.
Yeah, and you could definitely see that in what John mentioned earlier with the rates and some of those challenges there with the temp agency rates.
Well, I think the good news is you guys are controlling what you can control and doing a really good job at that. And there are things, trying to control as much of what you can't control
Exactly.
as possible. So,
But we are working with Natalia, right? And we're going to look at, the nurse salary structures and again, our dependence on contract nurses a little bit higher. I mean, obviously they have a great need and they've come and done a great job for us, but we would like to work on that balance of our own nurses versus being dependent on
We could
outside
maybe
nurses.
spice it up for our real
Yes.
nurses,
Spice
our
it up,
regular
yes.
nurses, give them something else. It may
Yes.
not be a big check, but it could be something else.
Yeah, we're going to look at that with her, so.
great. Matt?
I know we are short on time, so I will go quickly on value-based payment and managed care. We track and we'll try to present at every finance committee meeting our three major strategies for success in value-based payment: growing our membership, growing our risk surplus, and improving the quality of care. Progress on all three, working very hard and preparing for the end of the public health emergency to make sure we don't lose members. Our risk surplus is driven in part by that, but the work of our ACO is an example of our success in generating shared savings, one of only 11 in the country to have shared savings every year. And then strong results in our Metro Plus quality program, and I think helping contribute to them becoming a 4-star Medicare plan, which is a great result. And then the next page, just a couple quick bullets. Managed care contract is a little market sensitive, so we don't talk about it too much, but we've had a lot of great results over the last year. 10 new contracts and 15 renegotiations. A large national payer coming in network with us for the first time. Major work with Emblem, who we've had a lot of work with over the prior months, extending with United Behavioral Health, and then the overall revenue numbers, part of our overall success story. So just wanted to update on that, but on we go.
Wonderful, thank you. And test and treat.
Hi everyone, I'm Bailey. As you can see, we've rebranded from Test and Trace to Test and Treat. And over the past fiscal year, we incurred $1.32 billion of test and treat expenses. Those expenses were covered by revenue from OMB that they provide in accordance with our MOU that is still active. That revenue included CDC grants, FEMA funding, and ARP funding. And in FY22, we received $150 million of billing revenue at our T2 testing sites.
Okay, great. Any other questions from anyone?
Yes, I have a question. If you can please go to the cash on hand slide. I know it was one of the first, but I decided to wait until we
Yeah,
finish it.
thank you.
Yeah. I have two questions with respect to that metric. How seasonal are some of these numbers? Do we have a particular quarter in which we are lower in cash in hand while higher in others? And is there a possibility that in future meetings we can show the trend over the last year of cash in hand?
And I think that's a great question, and it's one of which that we put in front of the state, right, to sensitize them to that volatility. And when you think about 25 days cash in hand, that is not a lot of money. And the national average, right, for most hospitals is at least 10 times that amount.
10 times?
10 times that amount.
And John, the state itself defines a distressed hospital if they have, what is it, it's like less than 3 months?
Yeah, exactly.
Right,
Yeah.
so the state defines it as 90 days.
Yes.
As distressed. And
We are extremely distressed.
Yeah.
But yet we're not distressed.
Exactly. It's
We're
that
very
balance.
creative.
Yes, it's that balance. Yeah.
Let them call it distressed.
I think the other thing we try to, press upon the state and our partners at CMS is the importance of like having a more continuous flow of funds. And you hear us talk about UPLs and you hear us talk about DISH. They come in big lump sums. And, thanks to James, right, he keeps this all as best we can. We try to manage that. We would rather have those dollars actually get embedded into the rates and come to us every single time we provide a service. And 20% of our funding comes from these supplemental sources. So to the extent that we can embed those, into the fees that we get paid, we'll be, far better off. And it's another reason why we like value-based payment, right? Because it's a more, it comes into the risk pools, we can manage it. It's a more continuous, predictable stream. But it's a great question. And again, the volatility of that is like, we get down to 10 days sometimes and as high as 40 days, something, I mean, and again, we're just trying to smooth that out. But 25 days, right, is kind of, it's where we're at, and we're trying to get those days cash in hand higher. And it's, part of some of the discussions we want to have with CMS.
Okay,
John,
because that was my key question, but I didn't explain it. But I really would like to see that volatility if there is a particular month that is more day, year, or whatever. But I think I saw another measure that is very important with respect to this. Your account receivables was what, 78 days or 90 days, or am I remembering another data?
From the strategic planning meeting.
Planning?
It was from the strategic planning meeting.
No, I think it was like 40.
It's about 45, 47 days, I think.
45. So in that case, you can see the gap between those two measures. So maybe, I don't know, share.
Yeah, I'm just thinking, just because it's maybe implied, part of how James has to do this is to control the how we pay vendors. So the volatility would be much, much greater if it weren't for the great work that James and his team has to do. We cannot pay all bills as they come. We wouldn't make payroll sometimes. So we prioritize the small groups that we know really, have to get paid, or they would close themselves. And then the larger companies, we pay when we can. So that's just to say that the seasonal, the days is much flatter than the actual revenue coming in, because it's all really against the payment.
And you preempted my following question because it was the accounts receivables and accounts payable, and these three measurements, I think, I don't know how much we want to go into detail, but I think those three measurements will tell me a lot about the situation. But I will leave it to the chair. She's the
I think it's complicated by the relationship with the city as well, right? And how you get your funding and your timing.
Why can't we elevate that to the state and the feds, though? This is a very good argument.
I think we are, right? I think we are.
Better control also.
Yeah, I think we're trying to do that, right? Especially as it relates to the supplemental payments, because if we could get a more steady flow of funds, right, we wouldn't have to modulate how much we pay our vendors, right? We'd rather pay all of our vendors, right? It helps us even get better prices in the end. But it's this predicament that we really are trying to first start with the state and then also have conversations with CMS. Like we very much, we live off of those supplemental payments, but to the extent that we can increase them at the same time we make them more steady, we would be better off financially. And James would sleep every night.
Right.
Thank you.
We can do it.
Just a quick question unrelated to these. It's just, what is the United Behavioral Health Agreement? I just don't.
United Healthcare, as many health insurers do, subcontracts their behavioral health services to a vendor called United Behavioral Health. So it's a subsidiary of theirs. And we contract with them separately than with United Healthcare for the medical benefits. So we renegotiated our contract with them to improve our rates and terms.
All right, thank you.
And can I just, one last thing on the previous conversation is, you hear us talk more, right? We introduced it as part of the audit discussion about hitting the facility dish caps, right? And that's really, under federal rules, you can't draw in more dish than to cover your cost for serving the uninsured in Medicaid. And in my mind, that's slightly unfair, right? I mean, to only be able to make your cost. And shouldn't a safety net system that's 75% Medicaid and uninsured be able to earn some sort of margin off of that? And that would help us financially too.
And where would that have to change? That's
at the federal level with an act of Congress probably, but again, I think it's a great topic for us to discuss, and we're already starting it. We're starting with Greater New York, the other safety net hospitals.
Right.
The facility dish caps are put in place. It is a control mechanism for the federal government, but we're going to suggest that perhaps that should be modulated based on your level of Medicaid and uninsured. But that's a step, for the future here for us.
Right.
So that will be something with Deborah being very,
Yes.
very involved.
Yes.
And the value-based care, does that help us avoid some of this, or it doesn't?
Yeah, it's a good question. To the extent that we get dollars that we earn through like quality pools, right? Those don't count, right? In the facility dish cap. To the extent that we can earn money through the ACO mechanism, that doesn't count. So there's things there that we definitely want to explore, with the government. And again, that's why we prefer value-based payment. To the extent that you're rewarded and make margin based on meeting quality objectives, that seems like a pretty good model to us, and one that we should be rewarded for.
John, even in that model there, you probably know better than me, there's still some gaps. If we can get those gaps included, it would help tremendously.
Yeah, I think this is just, it's been part of our plan to actually, encounter and hit the dish caps, because it kind of opens up other opportunities for us, and filling gaps is certainly, part of that. But yeah, this is just something we'd like to discuss more with you.
Yeah.
As we develop our agenda.
Okay, great. All right, so maybe we can try to do an informational session on cash flow and how that all, we've done this before, and so it's probably beneficial for all of the members of the committee.
I will appreciate it because I would like to understand more about it, all those three measures. Yeah.
Okay. Any other questions? So do we have any old business? Any new business? There being no further discussion, meeting adjourned. Thank you, everyone. Great work.
This meeting is no longer being recorded.